Hi, everyone. My name is Alison Pouch, and I'm an assistant professor of radiology and bioengineering at the University of Pennsylvania. I lead a research group in computational medical image analysis. I'm delighted to be part of this Biophysics Week event. In the first 5 minutes of this talk, I'll describe how my academic journey has brought me to this point. I'll also describe 3 areas of methodology that my lab focuses on and how I envision translating these methodologies into clinical practice. Then I'll wrap up with some advice for people pursuing careers in biophysics. My journey to an academic research career didn't really start with a vision, but it was guided by sound. I like to say that because I was really inspired by ultrasound imaging research I did as an undergraduate. So I was an undergrad at the College of William and Mary. This is a picture of me and my dad on campus many years ago. And I was a double major in physics and anthropology. I was inspired by medical applications and took advantage of an NSF opportunity to work in the lab of Dr. Mark Hinders. He's a mechanical engineer who leads the non-destructive evaluation laboratory. My project involved developing ultrasound scattering models to count and characterize debris or emboli flowing through cardiopulmonary bypass circuits. I was really excited to work in the academic research lab environment. And I was also inspired by the idea that we could use medical imaging and physics to non-invasively characterize materials and also human anatomy. So from there, I continued with my graduate training in bioengineering at the University of Pennsylvania. I was in the Interfaces program, which specifically focuses on medical imaging and informational sciences. I continued along the lines of ultrasound imaging under the mentorship of Dr. Sandy Siegel, and also cardiothoracic surgeon, Dr. Rob Gorman. My dissertation involved taking 3D echocardiography, which is basically ultrasound of the heart, and developing advanced methodologies to extract 3D interactive models of the mitral valve like the one shown here. Our motivation for modeling the mitral valve is for surgical planning for ischemic mitral regurgitation, which is leaking of the mitral valve following a myocardial infarction. What we can do with these image-derived models is identify features preoperatively, like leaflet tethering, which indicate that a patient is not a great candidate for valve repair, but rather should undergo a valve replacement. I was really excited by this computational image analysis research, so I continued along these lines as a postdoctoral fellow in the Department of Surgery at Penn, and then as a research associate in Penn Radiology, under the mentorship of Paul Yushkevich, who is an image analysis scientist. During that time, I really sharpened my computational image analysis skills and began expanding our methods into new clinical domains, such as aortic valve modeling in 3D echocardiography, also modeling tricuspid valves of pediatric patients with congenital heart disease. So I also worked on placenta modeling in 3D ultrasound. And we were interested in doing this to identify features during the first trimester that might be indicative that the fetus is at risk for having low birth weight. This body of research ultimately grew into my current research program in the Penn Image Computing and Science Laboratory, or PIXL. My journey in academics is a little bit unusual in that my graduate, postdoctoral, and faculty roles are all at the same institution. The things I really love about this academic position are that I can carry out research, teaching, and mentorship and service in a great balance. Next, I'd like to tell you more about my research and also the vision of my research program and how it fits into the exciting fields of biophysics. The main idea is that we use medical imaging physics as well as image analysis as tools to understand organ morphology and function. In my case, we really use imaging to better understand the cardiovascular system and surgical interventions that can effectively treat structural heart disease. So I'd like to next give you a clinical scenario that really is the motivation for our research. So there are a number of different valve diseases, one of which is valvular regurgitation. This is not a disease that can be easily treated medically or pharmacologically. And when it's severe, it generally requires a major surgical intervention. So this is a very simple schematic of an operating room where a patient has come in for a heart valve procedure. It is routine for the anesthesiologist to first acquire echocardiographic images of the patient's heart before the operation is started. These images are critical to surgical planning. However, there's some limitations to current imaging strategies. One is that the images are oftentimes two-dimensional views of the valve, or the three-dimensional volume renderings only show the valve from a certain perspective. So the goal of our work is to take these images, develop advanced machine learning techniques for extracting models of the valve that can be displayed to the surgeon for visualization, and from which we can also derive quantitative measurements that can guide surgical planning. Just to emphasize why these images are so important, the surgeon often relies on an intraoperative inspection of the valve. So these are usually open heart procedures where the patient's heart is stopped, their chest is open, and the surgeon directly visualizes the valve in a flaccid or non-physiological state. This is a challenging process because there's no blood flow through the valve isn't pressurized, and the surgeon has to interpret the mechanism of defect of valvular regurgitation in order to correct it. It's a lot easier to appreciate valve morphology when extracted from the preoperative images because the valve is in a physiological state. So how do we get from these images to these valve models? And this is where I'm going to describe 3 areas of methodology that my lab focuses on. The first is image segmentation. So you probably know that images are basically arrays or matrices of pixels in 2 dimensions or voxels in 3 dimensions. And each one of these pixels is associated with grayscale or RGB values that form the image that we visualize. The process of image segmentation assigns an integer label to each of those pixels in the image so that regions with the same label have anatomical meaning. The word image segmentation comes from partitioning of the image into anatomically meaningful zones. This is an example of a 3D image segmentation of an aortic valve, where each integer label is represented by a different color. So here you have three labels for the aortic cusps and also labels for the sinus segments. And segmentations are really useful for visualization and measurements as well. So it can be somewhat challenging to reliably extract measurements from segmentations. For example, if we want to measure cusp surface areas or aortic root dimensions. So this comes to our second area of methodology development, which is shape analysis and computational anatomy. This is where we develop mathematical representations of anatomical shapes that we can use for standardized quantification of morphology and also statistical comparison of segmentations from different patients. To give an example of shape analysis, we might start with a shape model. And this is an example of a boundary representation of a simple oval-like shape. We want to use this shape model to capture the geometry of this target shape. So what we do is initialize the shape model and then perform an optimization so that the shape model captures the morphology of the target object. Then we can make standardized measurements using the coordinate system imposed by our shape model to make measurements like thickness of this target shape. We of course do this in 3 dimensions, and this shows triangulated mesh structures for the cylindrical aortic root, as well as the full aortic valve apparatus with the root and the fin-like aortic cusps. And from these triangulated mesh models, we have methods to standardize the measurement of cusp morphology and root geometry. The third area of methodological development is 4D modeling. So far, I've shown mainly 3D shapes, but we want to be able to track 3D motion and deformation over time. This is an example of aortic root deformation over the cardiac cycle derived from echocardiographic images. We use methods called image registration to find correspondences or mappings between consecutive echocardiographic images so that we can track the aortic root over the full cardiac cycle. We developed similar methods for the mitral valve. This is an example of a 4D extension of a technique called multi-atlas segmentation, which we can use to assess valve dynamics over the cardiac cycle and compare dynamics of normal mitral valves versus valves with valvular regurgitation. Now, those are three areas of methods that I'm really excited about, but how do we go about translating those into clinical practice? The first thing is we can certainly use those techniques just to learn more about valve disease and how disease valves differ from healthy, normally functioning valves. But another way that these tools are really important is deciding the patient-specific intervention. In other words, the surgery that is best suited to a patient's specific disease. So in terms of valvular regurgitation, there are two main surgeries that can be performed. One is valve replacement. This is where a prosthetic device is used to completely replace the regurgitant valve. Another option is valve repair. This is where the surgeon preserves as much native valve tissue as possible, but performs certain maneuvers to reconstruct valve competence. In general, valve repair is preferable over valve replacement when it's likely to be successful. But how does a surgeon decide whether a valve repair is likely to be successful? Well, they usually can look at some measurements based on the intraoperative exam, but we can also get those same measurements from preoperative image data. This is an example of computed tomography angiogram of a patient's bicuspid aortic valve, which is shown here. This is a congenital heart defect. There are a number of measurements that are useful for deciding whether a bicuspid aortic valve is well suited for repair versus replacement. Two of those measurements are related to valve symmetry and also cusp height and surface area. Those are measurements that we can make in advance of the patient entering the operating room. So the surgeon can decide in advance of the procedure rather than deciding in the OR. Another area of translation is patient-specific biomechanical simulation. This is an example where we took image-derived models of the mitral valve and left ventricle and used it for computational fluid dynamic simulation. So we could analyze fluid flow in both normal and regurgitant states. We can also use image-derived models of the mitral or aortic valves as input to finite element analysis to estimate stress distributions on the heart valve leaflets. These types of tools could help inform the surgeon as to which repair procedures may best normalize stresses on the patient's leaflets. These ideas are all leading to the idea of virtual surgery, where we can take preoperative images, output valve models, and then perform virtual maneuvers on those valve models and estimate how that will affect the biomechanics of the valve. So in essence, the surgeon would be virtually performing different surgeries and observing outcomes before the patient ever enters the operating room. And finally, the surgeries I described so far are very oftentimes open heart surgeries, but there's currently rapid advancement of minimally invasive approaches to valve repair. This is an example of a transcatheter device for edge-to-edge repair called the MitraClip. Without ever stopping the heart, the physician introduces this clip through the patient's vascular system and clips the leaflets of the mitral valve together so that it forces them to close properly. So for patients whose health status is not adequate for an open heart surgery, these transcatheter approaches are great options for heart valve disease treatment. The challenge of them is that the physician never directly visualizes the valve. They entirely rely on images like these to guide the procedure. So I believe that our tools in valve modeling can really advance these minimally invasive therapies by providing visualizations and also measurements like leaflet length in this case, which could help indicate which patients are best suited for these transcatheter approaches. So now that I've given an overview of my career, I'd like to share some advice for how you can make your vision for a biophysics career a reality. My first piece of advice is, of course, to engage in very rigorous training in whatever area of biophysics you're interested in. And there are 5 other general ingredients that I think make for a very successful career, no matter which direction you pursue. One is passion. Always follow what you're interested in because it's going to bring a lot of energy and enthusiasm into your work. Also find great, strong mentors who propel you forward in your career direction. No one succeeds in isolation, but really truly stands on the shoulders of giants who precede them. Also, continue engaging in the biophysics community as you're doing by watching this presentation. Don't be afraid to put yourself out there, meet people in different areas of biophysics, and also take advantage of internships to gain different career experiences. And also have a mindset for lifelong learning. No one develops expertise in some area of biophysics and just stays that way. It's a very interdisciplinary field that requires constant creativity and adaptation. And finally, grit. As anyone with a successful biophysics career probably had points in their journey that where luck was not on their side, and it requires some persistence and grit to get through those moments. But overall, it's a very rewarding journey, and I wish you the best. Feel free to reach out to me at any time with my email address here. Thank you again for your attention.